Okay, guys, um, do you see the screen now?
Yeah, we can see the screen.
Okay, very good, guys. So let's begin this nice and interesting lecture about the hypothalamic and pituitary hormone. Okay, so as I told you in previous lecture, this is not a lecture. Okay, this is a discussion, a debate lecture, a session. We create question, we answer the questions, and so on. Okay, first thing, we have these two structures called hypothalamus and also the pituitary gland. Is everything clear, guys?
Yeah,
Okay, so
we can see.
hypothalamus and pituitary glands are two glands are available in the brain actually. Okay, so hypothalamus are interconnected to other structure called pituitary gland. So both of these structures, the hypothalamus and the pituitary gland, responsible to synthesize, responsible to release number of the hormones. Okay, first thing, before going to which hormones are released here, let's see how these two structure, how these two glands are interconnected to each other. So who can answer me about that? How hypothalamus are interconnected with the pituitary gland?
Uh, can I answer the question?
Yes, of course.
So, if you really think about it, the pituitary glands or axis is basically like a protruding part of the hypothalamus. If you really think about it, differences we have like an anterior and posterior section. Hypothalamus just sends signals to those glands, and they release specific hormones based on specific, well, interactions and reflexes.
Okay, so you are Naveen Majid, isn't it?
Yeah.
Okay. Okay, dear Naveen, look, we have the hypothalamus and pituitary gland are overlaid, or let's say they are interconnected to each other by a structure called pituitary stalk. Okay, so what we mean by pituitary stalk, like in Kurdish we say sonda. Okay, it is a pituitary stalk that's contain a group of blood vessels and also fibers, nerve fibers. Okay, the group of the nerve fibers are called neurosecretory fibers. Okay, and we have the blood vessels, the group of blood vessels called portal venous system. So the hypothalamus are connected to the pituitary gland by number of fibers and number of blood vessels. So what is the difference between hypothalamus and the pituitary gland? Hypothalamus always responsible for synthesizing hormone. While what about the pituitary gland? Who can answer?
It basically releases hormones,
Oh,
specific ones.
okay, very nice. So we have two lobes in the pituitary gland. We have the posterior lobe and we have anterior lobe. Okay, the posterior lobe, it is only responsible for releasing hormone. Which kind of hormone? The hypothalamic hormone. Mean hormone are synthesized in the hypothalamus, released by into the posterior loop, and then from posterior loop into the systemic circulation. The connection between hypothalamus and the posterior lobe occur by the neurosecretory fiber. So this is very important point. Okay. What about the anterior lobe of pituitary gland? It's responsible for synthesizing and releasing, while the posterior it is only responsible for releasing. So this is one of the difference between the posterior and the anterior lobe of pituitary gland. The connection between hypothalamus with pituitary gland take place by the portal venous system. Okay, so now we have hypothalamus. Hypothalamus release hormone. This hormone called a regulatory hormone. Okay, this hormone not responsible in most of the cases, guys, to the physiological action, but it is responsible to either induce or inhibit releasing of pituitary hormone. This is why we called it regulatory factors or regulatory hormone. Is it clear till now?
Yes.
Okay. So, guys, I need your participation, please. Okay, so this is the pituitary, and this is the anterior, and this is the posterior. So all these hormones are released from the pituitary loop of anterior loop of pituitary gland. Like for example, growth hormone, adrenocorticotropic hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. All these are hormones are released from the anterior loop of pituitary gland. In response to what? In response to regulatory hormone synthesized within the hypothalamus, then released to the anterior loop, and then these are synthesized and released from the anterior loop. Okay. What we call the hormones in the hypothalamus? What's the name? What are the names, or what is the name of the hormones that are produced by hypothalamus?
Regulatory hormone.
Regulatory hormone, yes. So either releasing hormone or inhibitor hormone. Okay, very nice. What's your name, please?
Dylan Kawa.
Dylan Kawa. Nice to hear you, Dylan.
Doctor, what about oxytocin?
Okay, very nice question. This means he is betrayed us and he is going to study. Okay, so we have in the posterior loop, we have two hormones. We are going to talk about these two hormones. These are oxytocin and vasopressin. They are released from the posterior, so they are not synthesized within the pituitary gland. Okay, they are only released from the posterior loop of pituitary gland. So they are synthesized where? By this way. Guys.
Can you repeat the question, sir?
Okay. He said, "What about you?" Dylan Kao, I think he asked me.
No, it was me. Isa.
Isa. Okay. Isa, what? Your father name, please.
Isa Samir.
Samir. Okay. Isa said, you say that prolactin, growth hormone, thyroid stimulating hormone are anterior loop synthesized and released from the anterior loop of pituitary gland. So what about the vasopressin? What about the oxytocin? I told him that oxytocin and vasopressin actually they are not synthesized within the pituitary gland. They are only released from the posterior loop of pituitary gland. So the question is, what are the site for synthesis of these two hormones?
Hypothalamus, dear doctor.
What?
Hypothalamus?
Yes, of course. The answer is they are synthesized within the hypothalamus, then transported by which structure? Neurosecretory fiber or portal venous system?
By neurosecretory fibers, because they go to the posterior one.
Okay, what's your name?
Lavin Latif.
Lavin Latif. Okay, so as Lavin Latif said, any hormone, any things synthesized within the hypothalamus and transported to the posterior, it will be transported by the neurosecretory fiber. So this is great information. And what about the anterior loop? Anything produced within the hypothalamus and then transported to anterior loop, it will be transported by the portal venous system. Okay. So these are the introduction about the hypothalamic and the anterior loop of anterior and posterior loop of pituitary gland. Okay, so in last lecture, the previous lecture, we talked about the cortisol. So cortisol belong to which group of hormone?
They're like the building blocks, basically.
Okay, so it's
Also, like the building blocks for majority of steroids.
okay, so it's belong maybe to adrenocorticosteroids.
No, glucocorticosteroid.
Okay, glucocorticosteroid, yes, but glucocorticosteroid it's a part of adrenocorticosteroids. Okay, guys, because they are synthesized within the adrenal cortex. Okay, so we have three type of adrenocorticosteroid. One of them is cortisol, which is a glucocorticoid. What about the second one? Second adrenocorticosteroid.
Sorry, doctor.
Yeah,
Mineralocorticosteroid.
Mineralocorticoids.
very good. Mineralocorticoid. Okay.
The
Mineralocorticoid.
third one, adrenal androgens.
Adrenal androgen like testosterone and estrogen. And we talked about that the synthesis of these adrenocorticosteroid, cortisol, aldosterone, and testosterone, for example, take place as a result of activating the anterior lobe of pituitary gland by a regulatory hormone. So when we say regulatory hormone, mean it is synthesized within the hypothalamus. So this regulatory hormone called corticotropin releasing hormone. Okay, so corticotropin releasing hormone activating its receptor, which is present within the anterior lobe of pituitary gland, lead to synthesize the adrenocorticotropic hormone. And adrenocorticotropic hormone by itself, it released to the systemic circulation and act on the adrenal gland in order to produce the cortisol, aldosterone, and adrenal androgen. Let's talk about the cortisol, and this is actually a review for the previous lecture. What is the rate limiting step in biosynthesis of the adrenocorticosteroids? You can see from the figure, rate limiting step.
Rate limiting step was like if it doesn't occur, then the other steps in the reaction not occur. For example, if cholesterol did not go into a rate limiting reaction to progesterone, it would not like produce the other hormones and steroids and go the other processes.
Okay, very good. You are Naveen, isn't it?
Yes.
Okay, Naveen. So very good that the rate limiting step, it is the step, if it's not occur, the biosynthesis will not occur. So it is essential step. So what is the essential step here in biosynthesis of cholesterol, aldosterone, adrenal androgen? It is converting of cholesterol to this structure, which is called pregnenolone. Okay, so this called the rate limiting step in biosynthesis of all adrenocorticosteroid. Without this step, the adrenocorticosteroid will not synthesize. Okay, and we have also a rate limiting enzyme called cholesterol desmolase, which is responsible to catalyze, to mediate the reaction to go from the cholesterol to pregnenolone. Okay, so the activity of this enzyme induced by action of the adrenocorticotropic hormone. Okay, so adrenocorticotropic hormone synthesized within the anterior lobe of pituitary gland, then released into the systemic circulation, lead to activating of enzyme called cholesterol desmolase, which is responsible to catalyze the reaction of cholesterol toward the pregnenolone. And then from the pregnenolone, all the other adrenocorticosteroids are synthesized. Clear till now?
Yes, doctor.
Where is Paywan
Vamos,
Payro?
أزيد
Okay,
Vamos lá, برسيارك أزيد نبي.
go on please.
أم سلايدانا لي لنو حضركي إيمان يعني أصلا لما دعوت روان أما بوتجيشني خمانة.
Kaman, which one?
أدرينو كورتيكوتروبيك هرمونك.
Are you sure it's not available?
والله استسير مكردوتين أبو حزكي باجة ما أتي
با همانا
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 كان هي
همانا
أي نازم من محاضركم ده نسراب ولكتشري دو هرباسي هاي بوصلة أمانة قاعدتيني النازم.
Okay, kindly maybe you upload it again. Maybe there's some technical issue or something like this. Otherwise, if you see any defect that's differ from what I show you here now, so just tell me, I will re-upload it again, the lecture. Okay, guys?
سلايدي بينج سلايدي بينج هيا بينج وشش
دست خوش مام سايان لو تشكيش كلاي منابه دست خوش.
Okay, nice. Okay, guys, regarding the adrenocorticotropic hormone, we have many therapeutic uses for the adrenocorticotropic hormone. The first one I wrote here, it is a diagnostic tool. It can act to diagnose some diseases. Okay, so who can read this paraphrase, okay, and discuss it with us? Who can read it, please? The participator in the first lecture: Lina Twana, Ahmed Abu Bakr, Shema Omar, Avin Reboir, Ziria, Paywand, Arya, Niveen, and Soz. Today I just heard Niveen from the first lecture, and we have some new.
Can I explain if that's okay?
Okay, Niveen, go on.
For therapeutic use, for example, like you said, diagnostic tools,
Okay.
we can basically like diagnose people with specific diseases based on their hormone levels. For example, if there's primary adrenal insufficiencies, we can diagnose person by having Addison disease or adrenal atrophy or any kind of form of disease that attacks the adrenal gland, for example.
Okay.
And that's basically how I understood it.
Very nice. So it is a diagnostic tool, as Naveen said, in order to differentiate between someone suffering from a primary and someone suffering from secondary adrenal insufficiency. So if you ask me what's the difference between the primary and secondary, I would tell you that the primary adrenal insufficiency mean Addison disease. Again, if you ask me what's you mean by Addison disease, I would tell you that in case of Addison disease, there is no cortisol release because of adrenal atrophy, because the adrenal gland, the anterior lobe of adrenal gland, the cortical part of the adrenal gland, it is destroyed. So there is no releasing cortisol. So there is cortisol deficiency. There is cortisol crisis. In case of a secondary adrenal insufficiency, so it means there is cortisol. The adrenal gland release cortisol, but it is not enough. Okay, so how we can use adrenocorticotropic hormone as a diagnostic tool here? We say that adrenocorticotropic hormone, it is responsible to act on its receptor on adrenal gland and then release the cortisol. So we give such patient adrenocorticotropic hormone and then we monitor the level of cortisol. If there is increase in level of cortisol, mean his adrenal gland still working, okay? Mean there is no adrenal atrophy, there is no destruction. Still the adrenal gland working and there is response to the action of adrenocorticotropic hormone. So this is called secondary adrenal insufficiency and can be treated by medicine. But in case the primary, when we give adrenocorticotropic hormone, there is no response in cortisol level. The cortisol level will not increase. The adrenal gland will not synthesize and release cortisol. And this is called the primary one. So is it clear what's the difference between primary and secondary?
Yes.
Okay.
Primary, nothing works basically. Cortisol is not released. Second one there is, but not as much.
Not enough, yes, very good. So we have a synthetic analog, a synthetic adrenocorticotropic hormone called cosintropin. So this cosintropin is different from the first one. So who can imagine what are the differences or what are the advantages that cosintropin offer us in comparison to the natural one?
Maybe we can say because it's more pure
Yes, very
and it
nice.
does not cause like immune reaction in human, because we know if it's natural one from the animals, so it causes immune reaction.
Okay, Lavin.
That's one of the points.
Lavin Latif. Okay, so Lavin Latif, actually, she is mentioned a very nice and good information, which is about the purity, because the impurity lead to activate the immunological reaction. Immunological reaction mean maybe lead to hypersensitivity reaction, and this is may lead to a serious and life-threatening complications. Okay, what is the other advantage?
We can say since it's synthesized, lab made, we can have like greater quantity of the medication compared to natural extraction, which would take longer and like we would not produce much
Okay.
of it if you suck it from the animal directly.
Okay, the lab made mean it has a precise dose, so you can use the precise dose or same dose every time. But in case of the natural one, you cannot ensure that every time you get same amount, same dose, same concentration. So these are the two differences or two advantages that the synthetic one will impart us in comparison to the natural one. Okay, regarding the infantile spasm, what we mean by infantile spasm, who can say? Infantile spasm, it is epilepsy, okay? It is seizure, but this kind of seizure is differ from the normal one. It is occur in the babies, okay? So also the other name of infantile spasm, it is West syndrome. So why we give adrenocorticotropic hormone for treatment of such cases? It is not anti-seizure, adrenocorticotropic hormone. So why we give such medicine to such cases?
Okay.
Can I answer it?
Paywan, okay, let me see your name. Paywan Pero, okay, answer please.
Maybe to reduce the neuronal excitability.
Okay, how? Very nice.
To like it reduces those like neurotransmitters in the brain that cause the seizure. For example,
Okay.
it may be a sodium or GABA inhibitor. I don't know exactly which type of neurotransmitters, but logically it should reduce a neurotransmitter.
Okay, so very nice, and your answer is not, it is 100% right, but let's make it easier, okay? To be easier, we have adrenocorticotropic hormone, which is responsible to synthesize what? Responsible to synthesize cortisol. And the cortisol, it has two action, we say, anti-inflammatory action and also immunosuppressant action. So leave about the immunosuppressant action and let's focus on the anti-inflammatory action. The anti-inflammatory action of the cortisol responsible to decrease the inflammation of the brain. So this lead to decrease the brain excitability. Okay, decreasing excitability, as Paywan say, lead to prevent the transmission of the neurotransmitters. But we are not going to that detail. Just you must know that the cortisol has anti-inflammatory action and lead to decrease the brain inflammation. Decreasing the brain inflammation lead to increase the threshold of the seizure. So what we mean by increasing the threshold of seizure? mean the seizure will not occur again by simple stimuli. So we can protect that infant, that kid, that children from getting the seizure or epileptic process easily. So do you know why adrenocorticotropic hormone used for infantile spasm?
Yes, now it's clear.
Yes.
Okay, very nice. I'm happy. Okay. So about the growth hormone. This is growth hormone. We all heard about the growth hormone and we all familiar about that name. So growth hormone, it is hormone released from where? From posterior or from anterior?
Anterior pituitary.
From anterior lobe of pituitary gland in response to what? In response to regulatory hormone produced within the hypothalamus. This regulatory hormone called growth hormone releasing hormone. Okay? Because we have another regulatory hormone responsible to inhibit release the growth hormone. So we have growth hormone releasing hormone which is induce the pituitary gland anterior lobe to synthesize and release the growth hormone. While we have growth hormone inhibiting hormone which is called somatostatin. So somatotropin, it is growth hormone. Somatostatin, it is the hormone that inhibit release of growth hormone. Okay, so we all know that the growth hormone it is released in pulsatile form. So what we mean by pulsatile form? Who can define it? Who can clarify it for us?
Can I explain?
Yes, of course.
Pulsatile manner mean like it increases at certain times of the day. For example, for growth hormones, higher levels occur during sleep, okay, during nap time, where lower levels occur during daytime when the person is awake.
This is why the sleeping is so important for growth, especially in the children, isn't it?
Exactly.
Okay, we have synthetic growth hormone called somatropin. So these terms may lead to a bit confusion. So you must read it very carefully. We have somatropin, which is a growth hormone. Somatostatin, it is a regulatory hormone which is responsible to inhibit release the growth hormone, and we have somatotropin. Somatropin is synthetic form of growth hormone. Okay, so regarding, we have also somatomedins. Somatomedins are the worker that acting under supervision of the growth hormone. So what we mean by this, growth hormone has a two form of action: direct action or indirect action. The direct action, it is conducted by the growth hormone by itself. For example, activating the adipose tissue to induce lipolysis, inhibiting the glucose uptake by the peripheral tissues like the adipose tissue and the skeletal muscle, and also induce the protein synthesis. These are the direct effect which is mediated by the growth hormone by itself. Okay, regarding the indirect effect, the growth hormone induce or activate the hepatic system in order to synthesize two kinds of proteins. These are insulin-like growth factor 1 and 2. And these are responsible for a huge number of physiological action of growth hormone, like for example, induce the tissue and cellular proliferation, induce the bone growth. What we mean by bone growth? By bone elongation, and responsible for cartilage growth. Okay, this is why when we get old, our bone become weak and we exposed to osteoporosis because we have no enough growth hormone. Our cartilage and our joints all are we feel pain in this joint and cartilage. Why? Because we have no growth hormone, enough growth hormone, and in addition we have no intact skin. when we get old, and because this is lead to decrease the cellular and tissue proliferation. So now we have two action for growth hormone. We have the direct one and we have indirect one. Give me one example for the direct one. Only one example, guys.
Can I answer?
Yes, Paywand.
The direct effect, we see a lot of those bodybuilders that go to the gym. They use it to increase their muscle mass and decrease their fat mass in the body. So it directly helps with that.
Okay, so the increasing the muscle size, is it direct or indirect?
It's direct because it increases the protein synthesis, and by that way, it increases the muscle mass. I
Okay,
think.
so we have increasing in the protein synthesis. This is very nice information from you. And then we have to increase hypertrophy of the muscle, mean increasing the size of muscle. So this is also mediated by the indirect action of growth hormone. So regarding the increasing the muscle size, it is direct and indirect. And very nice topic you talked about. So what about the indirect? Who can give me one example?
May I answer your question?
Yes, Glenna.
For indirect, for example, we have children and he have growth deficiency. We have to give it for 3 months the GH stimulating hormones.
Yes.
So he has or she has to take it for 3 months. The effect is indirect.
Very nice. Okay. She said that if we have children suffering from deficiency of growth hormone, we give him growth hormone. Okay. So let's go to this this slide. Okay. So Glenna said children have growth deficiency. We give them growth hormone in order to replace the deficiency and improve the bone growth and improve the normal development. So we have some cases that the growth hormone is contraindicated or are contraindicated in some cases, like for example closed epiphyses. Who know about the closed epiphyses and when we will reach to the closed epiphysis situation? Okay, a closed epiphysis, when we say closed epiphysis, we have in the bone, and this is the structure of bone of child, and this is for the adult. Okay, the structure consists of number of segments like epiphysis, metaphysis, and diaphysis. This long shaft called diaphysis, and this long structure called epiphysis, and we have opening. Look, these blue maybe dots are the growth plates. Okay, look, it's available here too, and it's available here too. Compare it with the adult bone. There is no growth plate. There is no growth plate here, and neither here too. Okay, so these growth plate, from the name it is, they are growth plate, mean it is the site where the bone will growth, the site where the bone elongation it will be here. Okay, so if there is no growth plate, is there is no opening in the epiphysis, mean the bone cannot elongate more than this level. Okay, so we reach to the closed epiphysis in the male about 18 to 21 years old, in the female between 16 to 18, maybe in most of the cases. Okay, there is some special cases, but generally, normally in the male between 18 to 21. This why in most of the cases the males are longer than a female, and in the female between 16 to 18 years old. Okay, so if we give growth hormone to the children, and we have open epiphyses. These lines, let's see here, look, this is a true x-ray for the bone of child. So there is opening, okay, the growth plates are open, so there is a space that for bone to elongate. But if this space disappears, for example in the male after 21 years old, so the bone, when we give him growth hormone, the bone will have no space to elongate more. Okay, what will happen? Who can know?
Can you repeat your question, doctor?
Okay, we say that this open epiphysis, called open epiphysis, okay, mean that until this time, until this level, when there is open epiphysis, look, this opening, this line, open line, mean still the bone has possibility to elongate. But if this open disappeared, this line disappeared, mean there is no possibility to the bone to elongate more. There is no possibility for bone elongation. So if we give such patient, not patient actually, if we give such person growth hormone and he is over 21 years old, he has no open epiphysis, he has closed epiphysis, what will happen? What will be the complication?
Abnormal, I think it's cause abnormal bone thickening.
Avin revoir, okay, Avin.
Abnormal bone.
So you mean that there is no chance for bone to elongate, but there is...
Yes, it's called acromegaly, I think.
Yes, very good, very nice, Avin. Okay, so because there is no chance for bone to elongate, okay, it will take another pathway. What is the another pathway? Increase the thickness of bone. Like in this case, and like Avin said, it is a case called acromegaly. Just look to his hand. He suffer from thickness in the bone of hand, in bone of the face. Look to the jaw. Look to the bone of the face and the bone of the jaws and bone of his hand. Just imagine if this person slaps someone. Do you see the difference between this hand and the normal human hand? Is it clear, guys?
Yeah.
Okay. So actually, he is not taking growth hormone as a drug, but he is suffering from disease. In that, his growth hormone level, it is so high. This is why he suffers from the acromegaly. Look to the fingers. So thick fingers. Look to the jaw. Look to the face, to the nose.
Doctor, there is a problem with your internet. We cannot hear you very well.
You cut out sometimes.
Okay, let me connect on my phone. Just wait a minute. My phone internet. Do you hear me now, guys? Do you hear me, guys, now?
Yeah.
Okay.
Yes, it's better.
It's way better.
Okay, if there is any issue, just tell me, please. Okay, so we have this case which is called acromegaly. Okay, so who can define acromegaly kindly?
I said before abnormal bone thickening.
Okay, there is abnormal bone thickness because of what?
Because of the epiphysis.
Because of elevation in level of growth hormone, and because of this, that person, he is adult, he is over 21 years old, and he has no open epiphysis, he has closed epiphysis, so there is no possibility for the bone to be elongated more. So in addition, as a compensatory mechanism, the bone will get to increase its thickness in contrast to elongation. Okay, so this lead to acromegaly. Okay, also growth hormone can be used for treatment of something called Prader-Willi syndrome. Okay, so who know about Prader-Willi syndrome?
دكتور جان
بله.
دكتور هو بري الله يكسر هبو
Go on, please.
باشترين كات باشترين تمن تمن يا كبوي بو نام نالاني كتويسيان بكروز هرمون يعني بو كشكرني بالا تويسيان بهرموني سوماتوبين وري بقدر
before 16 years old.
لم نالان عفو
Before at the age of preschool, 7 years, 8 years, all these age are suitable for to give them growth hormone.
من أول خندومة ولا سدي الله باشترين كاد أويا بالضبط هرو كوكسكي جنابت الله لدو صالان لسه صالان تا هش صالان باشترين كاتا ويمنا لك زوتني إسفادي ليبكا وزوتني قشبكا لدواي دواء أو سودينية أي وراسته.
It is not a purely correct, but we can say the 100% of getting benefit from the growth hormone in the age of preschool. And here in Kurdistan, the doctors giving, making a committee about to give growth hormone for kids who's suffering from growth hormone.
دكتور جانيت بسياريكش ما هو عفون كي والله سوماتوبين كاريجري لسر هايبرغلايسيميا وانسولين ريزيستانس هي يعني
yes, it's lead to hyperglycemia, lead to anti-insulin effect. So what we mean by this anti-insulin effect, we know that insulin induce glucose uptake by the peripheral uptake, by the tissues uptake, sorry. So the growth hormone, it inhibits this process. You're welcome. Okay, so what about the Prader-Willi syndrome? Prader-Willi syndrome, actually it's a genetic disorder. This genetic disorder makes the kids eating too much abnormally, lead to increase the size, increase the weight gain, and in addition, he's suffering from a deficiency in growth hormone. Okay, so we give such kid or such children or such person growth hormone, but actually we give growth hormone in some cases of Prader-Willi syndrome, not all the cases. Okay, so if you ask me why, so it is simple and easy, because the growth hormone responsible to induce the soft tissue growth. Soft tissue, what I mean by soft tissue growth, mean like for example tongue, mean like for example the airways, the respiratory airways. So this may lead to exacerbation of already available respiratory problem in such obese patients or persons. Okay, we know that the obese suffering from sleeping apnea, for example, during the night or during the sleeping. So if you give them growth hormone, you may lead to exacerbate this situation, and in severe cases may lead to obstruction of respiratory airways and may lead to sudden death in some cases. So we have to indicate growth hormone for Prader-Willi syndrome if the patient, he is not still severely obese. Who can tell me what is the somatostatin?
It's the hormone that inhibits growth hormone release, or
Okay.
release synthesis in the pituitary.
Very good. What is the somatotropin? Just the name.
It's the one that causes, yeah, just the name, just growth hormone.
Growth hormone. What about the somatropin?
Somatropin was the synthetic form or the drug, I
Very
believe, if I
nice.
remember well.
What about the somatomidine?
They were mediators, like for indirect growth hormone, if I remember well.
Very nice, very nice. Okay, I need you to focus here. Okay, guys, this is very important topic. The gonadotropins. Okay, the gonadotropins mean follicle stimulating hormone and luteinizing hormone. Okay, these two hormones called gonadotropins. So the follicle stimulating hormone and luteinizing hormone, these two hormones working in harmony to each other. So what I mean by working in harmony with each other, just look, the FSH responsible to growth and development of the follicles, follicles that contain the ovaries. Okay, what about the function of LH? Induce the ovulation. Here, LH responsible to increase the production of androgen, testosterone. In case of FSH, responsible to convert that androgen, that testosterone, to produce estrogen. And this is a very good and very important information, because I will ask you a question later about this point. Okay. LH responsible also to increase production of estrogen and progesterone. But the point that I need you to know, there are two hormones, FSH, LH, both of them working in harmony. What I mean by working in harmony, one of them create androgen, the other convert it to estrogen. One of them responsible to increase the follicle development, the other responsible for ovulation. So these effects occur in the female. Okay, what about the FSH and LH function in the male? Because also it's present in the male. It's responsible to increase LH, to increase the testosterone level. Okay, in the male, and also FSH responsible to increase the sperm level production. Okay, we have menotropins. Okay, let me ask someone. Okay, Rojan Muhammad.
Yes.
Rojan Muhammad, kindly read this. Read about the menotropin. Read it and clarify it for us, please.
Clarify what?
Clarify what's written here. Just read it. Read it. So menotropin, it is extracted from where?
Teacher, your slides are not clear.
Why it's not clear?
I can't see it.
Okay.
Just a minute.
Is it clear now?
طلخة ما مستا طلخة لا من سلايدة كان.
Okay, what's your slides?
لا مش طلخة دكتور.
سلايدة كان هم يطلخن.
Okay. أي مو بستنى كل سرعة تشتيك ما بكرده.
والله استوى إلي هاد وأنا ببداية استطلخة.
Okay. باش. Menotropin, it is mixture of gonadotropin. Contain both. So when we say gonadotropin, mean FSH and LH. But in case of menotropin, the potency, the concentration of the FSH, it is just 4% of the normal one. Okay? What about the FSH, follicle stimulating hormone? We have a three form for FSH. We have the urofolitropin, we have the folitropin alpha and folitropin beta. Okay, urofolitropin, it's obtained from where? From urine of postmenopausal women. And it is extracted, then purified, then it is used. But what's the difference between urofolitropin and with menotropin? Who can answer?
Can we say like in minotropins it contains LH, but in the other one it doesn't have LH. LH has been removed.
Actually, very nice. Urofolitropin, folitropin, it is devoid of the LH activity. The LH, it is removed from this product. But in case of menotropin, contain both FSH and LH. But the FSH potency, it is only about 4% of normal FSH. So guys, let me ask you about review question. What's the difference between potency and efficacy?
Potency is related to the dose.
Okay, just let me write your name, Arya. Arya Haman. What is the potency?
Potency is related to the dose. For example, if we compare drug A and drug B, if drug A gives the same potency as drug B, but in lower dose, that drug is more potent. But efficacy relates to the effectiveness of the drug and how much effect it gives us.
Very nice. So potency related to the concentration of the drug related to the dose. So as Arya said, if we give two drugs, one of them 10 milligram and one of them 2 milligram, by both of them exert same effect, so the 2 milligram is more potent than efficacy because we use lower concentration of drug to exert same effect. Regarding the efficacy, it is related to the interaction between the drug and the receptor and then lead to effect. This effect called efficacy. Okay, very nice, Arya. Okay, so we have also synthetic form of luteinizing hormone called lutropin alpha, and it is indicated to be used in combination with folitropin to induce level of both LH and FSH. Is it clear the slides now?
والله يا دكتور راستك سلايدة كانت
لا والله ما سلايدة كانت تلخن.
بس با كونكت بكم لسر خاتيكي تربزانة باشتري به. گوێتان لێمە؟
بەڵێ گوێمان لێتە.
خەتەکە باشتر نەبوو؟
گوێمان لێتە عیبی نییە بەس سلایدەکانە تەڵخن.
ئەڵێم یعنی چاکتر نەبوو؟
ئەوسە تۆزە باشتر بوو.
ئێستا تۆزە ڕوون بووە.
تۆزە ڕوونتر بوو.
ئێستا باشتر.
ئەگەتوانی زوومی کەی باشتر بێ.
باش ئێستا؟
بەڵێ بەڵێ ئێستا تۆزە ڕوونترە.
ئێستا باشترە بێ. ئێستا تۆزە باشترە بێ. بزانم خەتە باشترە. Okay guys, بس من یک شتێکتان پێ بڵێم. I would like to tell you about the indications of the gonadotropin. Okay, gonadotropin, like what's gonadotropin? FSH and LH. Okay, gonadotropins are anterior lobe pituitary gland hormone released from the anterior lobe in response to what? To regulatory hormone called gonadotropin releasing hormone. So gonadotropin releasing hormone act on its receptor in the anterior lobe of pituitary gland, and then the FSH, LH released from the anterior lobe, synthesized and released. Okay, who can define what we mean or clarify what we mean by hypogonadotropic hypogonadism? So gonadotropins are used for treatment of hypogonadotropic hypogonadism.
كما بك pituitary gland prepays ل FSH و LH درنا لو hypogonadotropic hypogonadism مع
عفرم يعني ما بس you mean that hypogonadotropic mean there is no enough level of FSH and LH. Am I true? Am I right?
بلا بلا.
Okay. What about the hypogonadism?
It would be the condition, since the pituitary gland is not releasing enough FSH and LH, the individual will have low, basically no ovulation or like without LH and FSH stuff in uterus.
Because of deficiency of which kind of hormones? Hypogonadism.
Sex hormone.
Okay, like testosterone and estrogen. Very nice. So
Voilà.
hypogonadism mean it is a situation when there is not enough FSH and LH. Okay, this lead to not enough testosterone and estrogen level. Okay, so this is why gonadotropins, because it's induced the synthesis of FSH and LH, it is also induced the sex hormone synthesis. Okay. Regarding the adverse effect, we have two serious adverse effects. We have many adverse effects, but let's focus on these two adverse effects. Okay, multiple pregnancies and ovarian hyperstimulation syndrome. Okay, what are the complications of multiple pregnancies? Who can participate, please? Who can participate?
Sorry, doctor, can you repeat your question?
Okay, we have two kind of adverse effect or two serious adverse effect: ovarian hyperstimulation syndrome and multiple pregnancies. So why we are say that multiple pregnancy, it is a life-threatening or maybe serious side effects, serious adverse effect. Because of what?
Can I answer the question?
Yes.
In multiple pregnancies, just like written on the slides, for example, can lead to preeclampsia, damage of the of the uterus. I forgot the name of the other organ. Anyway, for example, in preeclampsia, or like sometimes in pregnancy, individuals can actually have insulin resistance, so continuous or multiple pregnancies can enhance diabetes risk.
Okay, so gestational diabetes is one of the complications. Preeclampsia, elevation of the blood pressure during the pregnancy, it is another complication. And the preterm labor, what we mean, why it is complication preterm labor? Because the fetus may be still not developed well. There is no medical stability for that fetus. What about the ovarian hyperstimulation syndrome? What are the complications like ascites, hydrothorax, hypovolemia, shock, and fever, and arterial thromboembolism? So just in two words, what we mean by ascites? Who know, guys? Ascites mean accumulation of the fluid in the peritoneal cavity, mean the cavity that's surrounding the abdominal cavity. So this lead to abdominal distension and pain. What about the hydrothorax?
There will be water basically in the chest.
In the chest, yes, mean accumulation of the fluid in the pleural cavity, the sac that's surrounding the lung. So lead to inhibit the expansion of the lung during the respiration and lead to shortness of breath and respiratory distress. So hypovolemia, what is the reason of hypovolemia?
Reduction in body fluid volume cause dehydration, I think.
Okay, hypovolemia caused as result actually of ascites and hydrothorax. The fluid will move from the blood into inside the abdominal cavity. So because of hypovolemia, what will happen to the blood level? Increase or decrease?
It would decrease since there's
Okay,
not enough fluid.
so decreasing the blood volume, what will happen to the blood pressure? Decreasing of blood volume lead to hypotension, decrease blood pressure. Decreasing hypovolemia lead to decrease the blood supply to the organ, lead to decrease the oxygen supply to the organ. So decreasing the blood supply to the organ and oxygen lead to a shock. Okay? What about the arterial thromboembolism? Mean a blockage of the blood vessel by the thrombus, and this is a life-threatening situation. This is why we say the ovarian hyperstimulation and multiple pregnancies are serious side effects. Okay, who can answer me this question? In men, we say that gonadotropin is responsible to increase FSH and LH. So the gonads hormone like testosterone will be elevated. So why in the men using gonadotropin for long term in high doses lead to gynecomastia?
Can I answer that?
Yes, of course. What's your name, please?
Some of the My name is Payman Pero.
Pero, okay.
Some of the testosterone in the male's body is converted to estrogen. So increasing the level of testosterone doesn't always mean that only the testosterone will increase.
Very nice.
The estrogen also will be increased. So they will encounter gynecomastia.
Very nice, Paywan. As Paywan said, testosterone is a precursor for estrogen, so increasing the testosterone over than the normal level lead to increased estrogen, and estrogen lead to impart the male some female characteristic, like for example the gynecomastia. Okay, I need you to focus here, guys. Okay, I think I take longer than the decided time for you. Is it okay for you guys?
Yeah, I believe class finishes at 2 actually. So I think we have still have time.
Okay, very nice. Okay, we have gonadotropin releasing hormone. Gonadotropin releasing hormone responsible to synthesis of what, guys? It is a regulatory hormone, or it is the hormone that is released from the pituitary gland. So which kind of hormone? Gonadotropin releasing hormone?
It's the regulatory hormone.
Regulatory.
Released by the hypothalamus.
Okay, so it's a regulatory hormone synthesized within the hypothalamus, and it's activate its receptor in the anterior lobe of pituitary gland, and then it's responsible to release the FSH and LH. Okay, focus on this point. Okay, these points. The first thing, gonadotropin releasing hormone, it is released into the pituitary or the anterior lobe of pituitary gland in pulsatile form. What we mean by pulsatile form? Mean there is release and there is a stop. Mean there is gap. Then there is release and there is gap. Release and gap, release and gap, and so on. So this gap, it is about 1 to 2 hours in most of the cases. Okay, so the gonadotropin releasing hormone, focus on this point because I will ask you a question, and this is very important question. Gonadotropin releasing hormone, okay, agonist, or let's focus on the natural hormone now. Gonadotropin releasing hormone released in pulsatile form, mean there is release and stop, and so on. Okay, so the growth gonadotropin releasing hormone increase FSH and LH. FSH and LH lead to increase the gonads, the testosterone and estrogen. Let's see the therapeutic indications. Gonadotropin releasing hormone agonist. Okay? It is used for treatment of prostate cancer. And prostate cancer, we all know it is respondent to the level of testosterone. Mean increased level of testosterone lead to increase the size of prostate cancer. So how logic using gonadotropin releasing hormone, which is responsible to elevate the testosterone, to be used in treatment of prostate cancer? This is point. The second point, we know that LH and FSH responsible to improve or develop the ovarian follicle, and also it's responsible for ovulation. So how logic to use the gonadotropin releasing hormone in preventing the premature ovulating by inhibiting the LH surge? In case of endometriosis, in case of fibroid, these are cases that responded to estrogen. FSH, LH increased level of estrogen. So how possible to use this agonist in treatment of these cases? Who can think about it and give us a clarification?
Doctor, can I answer your question?
Okay, just tell me your name, please.
Soz Nasraddin.
Soz Nasraddin. Okay, Nasraddin. Okay, Soz Nasraddin. Can you please?
Gonadotropin releasing hormone used during the prostate cancer because this hormone is caused by the reduction of the testosterone, and this reduction, this level of testosterone causes to the stop this growth, this cancer. I think that's the mechanism of this drug.
Okay, the final outcome of using the gonadotropin releasing hormone, it is declining the testosterone level and then decrease the size of prostate cancer. But gonadotropin releasing hormone responsible to increase FSH and LH. So mean it is increase the testosterone level.
No, doctor. By the long-term uses, this medicine causes the reduction of testosterone.
Okay, you still Soz?
Yes, Soz.
Okay, Soz. So Soz say that using the gonadotropin releasing hormone agonist, not antagonist, agonist for long term lead to reduction in testosterone. Who can deal with her? Who can obey her answer?
She's right, doctor. Shania, and
you are. What's your name, please? Shania Omar.
Yeah.
Shania Omar. Okay, same. Okay, Shania Omar. You say that Soz Nasraddin, she is totally right.
Yeah, because gonadotropin releasing hormones, like we said before, when it's pulsating, it stimulates the release of FSH and LH. But when it's in continuous form, at first the ratio and the release of FSH and LH is going to be increased. But then eventually, because it's not pulsating, it's not in the natural form.
Very nice.
And it's continuous. So this causes like the downregulation of the receptors, causing the release of LH and FSH to be decreased.
Okay.
So it's like kind of inhibiting, which causes the decrease of testosterone, which also causes the growing of the tumor.
Okay, from the next week you give the lecture, okay? Because really nice clarification. We have natural rhythm for the hormone. As I say to you, there is a pulsatile release. So when we mimic the pulsatile release, so mean we have agonistic action, we will increase the FSH, we will increase LH, and then we will increase the gonads. Okay, but if we counteract this, the normal rhythm, the natural rhythm, mean we not give the gonadotropin releasing hormone agonist, okay, the medicine, but in non-pulsatile form, continuously, in sustained form, okay, mean we will have antagonistic action. Okay, so the agonist acts as agonist and may act as antagonist. As act as agonist when we give it in pulsatile form, act as antagonist when it is in continuous form or non-pulsatile form. So we have a phenomena called biphasic response to the gonadotropin releasing hormone agonist. What we mean by phasic response or biphasic phenomena, that when we give the gonadotropin releasing hormone in non-pulsatile in continuous form, we will have first the flare phase. What we mean by flare phase mean in the first 7 to 10 days there is a dramatic increase in level of the hormones FSH, LH, estrogen, testosterone. But after the 7 to 10 days the level going to decline, and this is why we use the gonadotropin releasing hormone in treatment of prostate cancer, because after the 10 days, okay, after 10 days the level of testosterone will decline. Let me go to the next question. Within these 10 days the level of testosterone increased largely, increased dramatically, okay, so this led to deterioration in what? Deterioration in the situation, the prostate cancer. So what we must do to prevent this deterioration, what we must do to prevent the flare? Guys, who can know? Do you hear me, guys?
Yes, we can hear you. Can you repeat your
Okay, I said
question?
regarding the prostate cancer, and also about the biphasic response. If we mimic the natural rhythm of gonadotropin releasing hormone, we will have agonistic action. But if we counteract this natural rhythm, mean this pulsatile form release, we will have antagonistic action. But actually this antagonistic action occur after 7 to 10 days. Within the 7-10 days, even we give the drug in non-pulsatile form, in continuous form, still the FSH and LH will elevate. Okay, so as a result of elevating in the FSH, LH, the testosterone will elevate, so it will deteriorate the prostate cancer. So of course the testosterone will act on its receptor on prostate cancer and lead to increase the size of prostate cancer. So what we do in order to inhibit the bad effect within these 10 days? Now just give me your logic answer, okay, because we will answer it in the next slides. Guys, we use gonadotropin releasing hormone agonist in treatment of prostate cancer, and the dose will be continuous in non-pulsatile form, okay. So after 10 days, maybe after 7 days, okay, the level of testosterone decreased and the decline, and the prostate cancer size will decline, okay, and lead to improve the symptoms. But within the first 7 to 10 days, because we said after 10 days the testosterone decline, within the first 7 to 10 days the level of testosterone increased too much, so lead to increase the size of prostate cancer. So in order to inhibit the action of testosterone on its receptor on the prostate cancer within these 7 to 10 days, we use androgen receptor antagonists, like for example flutamide, like for example bicalutamide. Okay, so these are inhibitor of the testosterone receptor, mean inhibit the interaction between the testosterone with its receptor. So within the 7-10 days level of testosterone elevated, but the testosterone unable to bind its receptor, so it will not lead to increase the size of prostate cancer. Is it clear now?
Yes, it's clear.
Very nice. Okay. Okay. We have gonadotropin releasing receptor antagonist. So we talked about gonadotropin releasing hormone agonist, which can act as inhibitor effect, has inhibitory effect and stimulatory effect. Okay, the inhibitory effect, when we will get stimulatory effect and when we will get inhibitory effect. So I need one of you to tell me about the stimulatory effect of gonadotropin releasing hormone agonist.
We did say that in gonadotropin releasing hormones, it basically in post-hormonal, it leads to increase in LH and FSH. That's for the agonist.
No. Just I need to review the gonadotropin releasing hormone agonist now. Okay, we have stimulatory effect and we have inhibitory effect. So when we will have stimulatory effect and when we will have inhibitory effect.
Well, if it's pulsating, then we have a stimulatory effect.
Very
and
nice.
if it's continuous, then we have an inhibitory effect.
Very nice. So depend on the way you give the patient the drug. If in non-pulsatile form, it is antagonist, inhibitory effect. If it is in pulsatile form, so you will mimic the natural rhythm, so it is agonistic action or stimulatory action. Okay. The slides are clear now, guys?
Yeah, we can see the slides.
Okay. So now let's shift to the new group called gonadotropin releasing hormone antagonist. So who can tell me what is the advantage of this antagonist over what? Over the non-pulsatile form receptor agonist. Gonadotropin receptor agonist.
Doctor, can I?
Yes. What's your name, please?
I'm here. So Nasruddin.
Soz Nasruddin. Okay, Fermo.
Yeah, the common side effects of the gonadotropin antagonists, like the prostate cancer, because this drug causes to the lower testosterone level and cause this disease become severe.
Okay, so you mean that gonadotropin releasing hormone antagonist, it is act immediately on its receptor, which is present on anterior lobe of pituitary gland, and inhibit activating of this receptor and immediately inhibit release LH and FSH. And so there is no biphasic response. So there is no what? A flare. There is no 7 to 10 days increase in level of the hormone. Is that what you mean?
Yeah, I mean by that the common adverse effects like the prostate cancer therapy. If you take the gonadotropin antagonist, these cases become severe, not treated.
An
Because
antagonist
the
or
gonadotropin
agonist?
antagonist.
Why it become severe, the prostate cancer?
This medication blocked the gonadotropin receptor in the pituitary gland and
Okay.
inhibiting the secretion of the FSH and LH.
LH. So lead to decreased level of testosterone.
Oh yeah, that's right. I'm sorry.
Okay. So it is good for the prostate cancer, just like the gonadotropin releasing hormone agonist, but we have advantages here over than the agonist one in that there is no biphasic response. There is no in the beginning increasing then declining. Here there is declining directly, okay? Because there is no flare. There is no giving the if we give the drug in form of pulsatile and non-pulsatile, giving the antagonist of gonadotropin releasing hormone receptor lead to directly inhibit the FSH and LH. Is that clear? The differences?
Yeah.
Yes, it's clear.
Okay. Prolactin hormone. So we have prolactin, oxytocin, and vasopressin. We will finish. Okay, guys. Prolactin. What is the prolactin? It is the hormone that is responsible from the name. Hormone responsible to synthesize to produce what? Milk production. So this prolactin hormone, it's induce the milk production when there is a normal level of estrogen, when there is a normal level of progestin, corticosteroid, and insulin. So we have two situations. We have either prolactin high level or low level. So the deficiency in the prolactin lead to what? Lead to failure in production of milk and also lead to defect in luteal phase. Okay, guys, do you hear me?
Yeah, we can hear you.
Okay, so deficiency in prolactin. Prolactin, it is a milk production hormone, as I say, but deficiency in the prolactin lead to some complications, some situations. The first one, it is normal, decline in level of milk production. The second one, it is luteal phase defect. So what is the defect? Luteal phase defect. Who know when the luteal phase will occur?
Luteal
During
phase
ovulation.
happens after ovulation.
Okay, after ovulation, and it is stand for how many days? For about 14 days. Okay, and during the luteal phase, there is a secretory gland produced. What's the name of that secretory gland?
Progesterone?
Okay, just very nice. This is the outcome, but there is a secretory gland called a corpus luteum. Okay, this corpus luteum responsible to produce the progesterone, to maintain the normal level of progesterone. Okay, and we all know that progesterone it is required to maintain, to stabilize the pregnancy. Okay, if there is no luteal phase, so there is what? There is infertility. Do you agree with me, guys? There is, if there is no luteal phase or there is defect in the luteal phase, mean there is defect in the reproduction, mean there is defect in the fertility, mean there is female infertility. So declining level of prolactin lead to failure in production of milk or not produce enough milk, and also lead to female infertility. Okay, what about this is regarding the deficiency. What about the hyperprolactinemia? How many cases, how many situations that lead to hyperprolactinemia?
Doctor, we can't hear your voice cut out.
Okay.
You can repeat whatever you said.
Okay.
That'd be great.
From where? From the Do you hear me regarding the deficiency of prolactin?
Hyperprolactinemia.
Okay, from the hyperprolactinemia. Regarding the
No,
hyperprolactin...
we heard you at that. We didn't hear you at hyperprolactinemia.
From the hypo or from the hyper? From the hyperprolactinemia, guys? My sound is interrupted.
Your voice is cutting out for some reason. Like, yeah, your voice disappeared again. We couldn't hear you at the hyperprolactinemia part.
Okay, the hyperprolactinemia, we have many reasons for hyperprolactinemia. Who can tell me one of these reason?
We can say in the case of...
Go on, Naveen, toss it.
Go, one of you,
Okay.
kindly.
We can say in the case of tumors or cancer, tumors sometimes can excrete hormones excessively. In this case, we can say tumors can also lead to an increase in prolactin release.
Okay, very nice. So we have
And the
other one is
doctor.
After labor, I think.
what?
After labor, I think.
Okay, we have, look guys,
Hypothyroidism.
Okay, we have many cases, we have many situations actually. The first one, as you say, there is a tumors, benign tumors that affect the anterior loop of pituitary gland, like for example prolactinoma and also pituitary macroadenomas. Okay, and we have another situation that it is called hypothalamic distraction. Okay, hypothalamus responsible for production of a hormone called dopamine hormone. Do you hear about the dopamine?
Yeah.
Okay, so the dopamine hormone, it is a regulatory hormone of biosynthesis of prolactin. So there is inverse relationship between the dopamine and the prolactin. What I mean by this, increasing level of dopamine lead to decreased level of prolactin, and vice versa. Increased level of prolactin mean there is low level of dopamine. So the dopamine, it is a regulatory hormone for biosynthesis of prolactin. Okay, so in case of hypothalamic destruction, mean there is no enough level, or maybe entirely completely there is no dopamine biosynthesis, and there is no dopamine secretion. So this lead to increased level of prolactin. So hypothalamic destruction and the tumors, benign tumors that affect the pituitary gland, responsible to elevate in level of prolactin. So what are the complications from the hyperprolactinemia?
Excessive milk production, for example, in galactorrhea.
Galactorrhea and?
I think absence of menstruation.
Menstruation, yes. What about the men? Lead to lose of libido and infertility also.
Infertility,
Yes, and infertility in the men. So very nice, guys. Okay. Regarding the prolactin, if we have high level of milk production and we need to cut off the milk production, which kind of medicine we must prescribe, we must dispense to our patient?
Dopaminergic medication. Those are increased dopamine levels.
Dopamine antagonist.
Dopamine agonist.
Okay, so we must give dopaminergic or dopamine agonist. Very nice. An example of these dopamine agonists like bromocriptine, caprgoline, and quinagolide. Okay, in our market, I see these two products, bromocriptine and caprgoline, and they are used widely by the gynecologist to cut off the undesired milk production. Okay, now the last topic, it's about the posterior pituitary hormone. We have two kind of hormones. We have the vasopressin hormone and the oxytocin. So tell me, true or false, the vasopressin, it is synthesized within the posterior loop of pituitary gland and released directly into the systemic circulation.
False.
False. What's your name?
Dilan. Dilan Kawa.
Dilan Kawa. Okay, Dilan Kawa. Dilan Kawa say false. Who agree with him?
I also agree, it's also false.
Okay, very nice. Because the posterior loop of pituitary gland not able to synthesize. It's only able to release the hypothalamic hormone. So responsible to release the vasopressin and oxytocin, which they are synthesized within the hypothalamus. Okay, the oxytocin, let's talk on oxytocin. Oxytocin has three therapeutic uses. Okay, the first one, it is inducing the uterine smooth muscle contraction. So it is responsible to induce the uterine contraction during the delivery, birth delivery. Okay, but in case of we have not enough contraction, so we can augment the contraction of uterine smooth muscle by also oxytocin. So regarding the uterine smooth muscle, we can either induce or augmenting the contraction. What about the milk ejection? It is also without the oxytocin, there will be no milk ejection from the breast. Okay, so the prolactin responsible to biosynthesis or lead to synthesis and induce production of milk, but the oxytocin responsible to eject this milk out of the breast. Okay, so oxytocin and prolactin working in harmony to each other. One lead to produce, the other it is responsible for delivery, responsible for ejection. Okay, the mammary alveoli, they are the cells that are responsible to produce the milk. Okay, surrounding this sac, this mammary alveoli, there is myoepithelial cell. So the oxytocin responsible to contracting this myoepithelial cell and lead to releasing the milk. Is it clear till now, guys?
Yes.
Very, very, very nice. Okay. Okay. Let's focus on this point and let's clarify it. Oxytocin also used for something called oxytocin challenge test. Okay. So today we didn't hear about Arya. Arya and Ziria, they are not participated and they are participating the first week.
No, I participated once about the efficacy and potency.
Yes, Arya Haman, yes, I wrote your name. What about Ziria? Ziria, where are you?
دكتور أبدأ أبرد وزن قرص بو أبرد بس جاب قرتوا.
عندي يلا ليش الصاغبة؟ أوكي.
دكتورة قرتوا درجة لسر أكتيفيتي كان داني ببورا بسكا شبه برمبلا إما بجدي معلومات مع لسر درسانة نية.
من
يعني قروا بحكي ما ويخري.
Look guys. First thing, this is a discussion session, okay? I already posted the video for you on your platform, and it's available from the Monday, okay? So you must read your lectures, okay? Actually, I'm not going to give grades on this participation, but it will be very nice when you participated, and you will understand better when you participate.
إذا هالسلايد هي يعني هتاخد بما شرحنا كي هتاخد باسينا كي هيك معلومات منية لسري كبرسياري شكي والله ينهزم جوابها معه.
Okay, it's okay. So what's your name, please?
روجان.
Okay. Rojan. So I'm not going to punish you or punish anyone if he is not answering. I am asking you for one reason, for two reasons. The first one, if you know, you will tell us, and by this way you will review your information. The next one, if you not know, I will clarify it more. Okay?
Okay, thank you.
No, you're welcome.
Uh,
Okay. Regarding
but
the
I kind of want to ask you something.
What?
Can I ask you something?
Yes, of course.
وش classically مش in a live session يعني you could explain to us also like asking questions.
Okay, I debate that about with the faculty. It's for me. It's so normal, and it is a bit easier for me. Much easier, not a bit.
It would be easier for us too. We could focus, and you can ask us
Okay,
questions. It
but
would be like focusing more.
maybe from the next week. But if I give you a live session, sometimes there is a net interruption. Okay, so may this affect on your retention, on your focusing ability. So if you like to give you a live session, yes, it's with my pleasure.
Yeah, it's okay. We actually would love the live session. It helps us a lot, honestly. The videos are too long sometimes, and if you could know, like yesterday we had issues accessing the video since it was privated on accident.
Yes.
It'd be way better, honestly.
Okay. So do you like the way that we do it now? Live video and then live session?
Yeah, that would be great. Like the video and then live session where we like you can explain stuff and also ask us. That'd be also good.
Okay, very good.
But just the session would be very hard for us. Like just like Rojan said, sometimes we can't access the video or like we can't really read everything. So having a live session where you explain stuff for us, just like a normal class, and also ask questions, that'd be way better for us.
Okay, very nice. So regarding the something called oxytocin challenge test, what we mean by oxytocin challenge, we need to test whether this fetus that are present inside his mother body is he able or can tolerate the vaginal delivery or no. So we do test called oxytocin challenge test. We're giving the mother a low dose of oxytocin in order to induce a mild uterine contraction. And after that, we will monitor the heart rate of the fetus. If there is decline in the heart rate of the fetus, mean that fetus not tolerate the vaginal delivery. But if the heart rate stay normal and there is no any decline in the heart rate, mean that fetus able or tolerate to the vaginal delivery. Okay, so do you know what we mean by oxytocin challenge test now?
Hello guys.
Oxytocin challenge test. Do you understand what I mean by oxytocin challenge test?
Yeah.
Very, very nice. Okay, guys. Okay, we have oxytocin antagonist like atosiban. It is responsible to inhibit the action of oxytocin, inhibit the interaction between oxytocin with its receptor, so lead to inhibit the contraction. Okay, this is called autocolysis process, and I think in the next week we will talk about the tocolysis and tocolytic agent in more detail. Inshallah, I will see which topic we will take in the next week. Okay, the next and the last hormone of our session, which is vasopressin. Vasopressin, also called antidiuretic hormone or ADH, which stands for antidiuretic hormone. It has two action. First thing, it has antidiuretic action, mean inhibit the urine, the fluid secretion, mainly to decrease the volume of the urine. So when we decrease the urine volume, mainly to increase the water or fluid reabsorption. Increasing the fluid reabsorption lead to increase or decrease in the blood volume.
repeat the question again, Doctor?
Okay, vasopressin, it has antidiuretic action, mainly to inhibit the fluid secretion. Okay, so lead to decrease the renal volume. Decreasing the renal volume lead to increase the fluid reabsorption, lead to increase the returning back of the fluid from the nephrons directly into the systemic circulation. So this effect lead to increase or decrease the blood volume.
It will increase blood volume since
Okay.
more water will be retained.
Increasing the blood volume lead to increase the blood pressure or decrease blood pressure?
It will increase blood pressure.
Increase blood pressure, and this why vasopressin, it is a hormone that is synthesized in the hypothalamus and released from the posterior lobe of a pituitary gland in response to decline in the blood pressure, in response to abnormal decline in the blood pressure. Okay. It has another action, which is a vasopressor action, mean induce the contraction of the blood vessels. So it will normalize the blood pressure by two pathways. The first thing, by decreasing the urine volume, increase the blood volume. And the second one, it is because of its ability to contract the blood vessel. Okay? We have desmopressin. Desmopressin, it is available in our market actually in tablet form and in intranasal form and maybe in injectable form and so on. So it is synthetic analog of vasopressin. Okay. Vasopressin act on receptor called V receptor, mean vasopressin receptor. We have two subclass, V1 and V2. So these V1 and V2 are belong to which kind of receptor? G protein coupled receptor. We have many subclass of classes of G protein coupled receptor, like for example GS, GQ, GI. What we mean by GS, GQ, GI?
The places where the receptor is, doctor?
GS mean G protein coupled receptor, but the S, it stands for what? How many subclass of G protein coupled receptor we have? We have GQ, GI, GS. So what's the difference between GQ and GS and GI?
Inhibitory, stimulating, and
very nice. GI, it is the inhibitory one. What about the GS?
Stimulating.
What about the GQ?
I don't know this.
Stimulatory too. Okay, so we have GQ, GS stimulatory by different mechanism, and we have the GI. It is the inhibitory one. Okay, so the vasopressin, it is belong to the GQ and GS. So it is a stimulatory receptor, and vasopressin act on to activate this stimulatory receptor. So activating V1, which is present in the blood vessel, lead to vasoconstriction. Activating of V2, which is present in the kidney, lead to decrease urine volume, mainly to increase water absorption, and then increase blood volume and increase the blood pressure. Okay, but we have another kind of V2, which is located outside of the kidney, located in the endothelium, located in the endothelium. What I mean by endothelium, it is the lining of the blood vessel. And these V2 that's present in the endothelium or in endothelial cell, responsible to release clotting factors, like for example clotting factor 8, like for example von Willebrand factor, and these are very important for blood clotting. And we have disease like for example hemophilia characterized by deficiency in factor 8. This why you see in some cases the doctors prescribing vasopressin or desmopressin for hemophilia. So from now on, You will not ask why he giving a antidiuretic hormone to treat the hemophilia. Okay, because now you know that desmopressin or vasopressin acting on extrarenal V2, which is present in the endothelial cell, which is responsible to induce release of clotting factor. Okay? Is it clear, guys?
Yeah. Very clear. Thank you.
Welcome. Okay, so we have also antagonist for vasopressin. We have conivaptan and tolvaptan. Okay, so the conivaptan has high affinity for V1 and V2. So what is the outcome from antagonizing the action of V1 and V2? V1, it's present where?
On blood vessels.
Okay, and V2 responsible for it's present in kidney and maybe extrarenal. But let's focus on V1 and V2 in the kidney and the blood vessel. So blocking the activity of V1 in the blood vessel lead to what?
For example, if you block V1, reduce blood pressure or like vasoconstriction, leading to dilation.
Okay, regarding the V1, lead to increase the urine volume and decrease the blood volume, and again lead to hypotension. Okay, regarding the V2, activating the V2 inhibit the activation of V2, lead to vasodilation, and this is another mechanism by which lead to counteract the action of vasopressin. What about the tolvaptan? It's act on, let's say it has higher affinity for V2 than the V1. So who can clarify the action?
Can I answer?
Yes, of course you can.
It causes more water excretion by kidney without losing sodium, of course, useful in hyponatremia.
Okay, so tolvaptan act on V2. Okay, so V2 is present where, in kidney or in blood vessel?
In kidney.
Okay.
In kidney.
Very nice. Okay, so lead to increase or decrease urine volume?
Increase, because it causes more water excretion.
Okay, so lead to more water excretion, increase the urine volume and decrease the blood volume. Okay, so it's counteract only half of the vasopressin agonist. Okay, while the conivaptan, it has activity or antagonized the vasopressin action entirely. Is it clear, guys?
Yes.
Okay, guys, so this was our lecture today. Actually, it was not a lecture, it was a discussion session. So I'm so happy to be with you. But just let me take the attendance, please. Ahmed Abu Bakr, but open your camera, please, guys, because it is mandatory in case of attendance.
I'm here.
Guys, please turn on your camera, please. Okay, Ahmed Abu Bakr, all of you guys, because the one who not open the camera, I can't sign him attendant. Okay, Ala Dilshad.
Yes, doctor.
Where are you, Ala? Okay, Ala, you are present.
Yes.
Okay, Ari Sirwan. Ari Sirwan. Okay, very nice, Ari. Arkan Sharif. Arkan Sharif. Arkan Sharif, where are you? He was present.
Yeah, it's still here.
Arkan Sharif, kindly the camera, okay. Maybe you are playing PlayStation. Arya Hemen.
Here.
Arya Hemen, please your camera.
Yeah.
Are you sick? Or
At the dental clinic.
okay, okay. Avin Reboir.
Yes.
Yes. Nice. Awin Amir.
Yes.
Yalla. Very nice. Aji Bakr. Aji Bakr. Okay, Aji Bakr. Bala Azad.
Yes.
Okay, Bala Azad. Balen Abdel Qadir.
والله دكتور جان.
Balen, I know you. Okay, Dilan Kawa.
بلى دكتور جان.
Okay, Dilan Kawa. Dunya Malik.
Yes.
Dunya Malik. Okay. Isa Samir.
Yes.
Okay, Isa. Fatima Haytham Mansour.
Yes, doctor. Yes.
Okay. Gilena Salam.
Yes.
Okay, Gilena. Giveen.
Yes.
Okay, Giveen. Camera, please. Okay. Hello, Muhammad.
بلى دكتور.
صاحب بلدي. هاوري عيسى.
والله دكتور.
ولك وي.
برا يقال.
لاري نوروز.
Bala doctor.
Okay, لاري كاميرا.
Bala doctor.
Switch on the camera, please.
دكتور كرمو.
Okay, okay, that's خوش. Okay, لافين لطيف.
بلى.
Okay, لافين صالح.
بلى.
Okay, لافين صالح. لينا توانا.
Yes.
Yes, Lina Twana, where is your camera, please?
I opened it.
Okay, thank you. Okay, when you open, say something because your camera will be disappeared in my screen. Muhammad Farouk. Muhammad Farouk Ali. Okay. Niveen Majid. She is present, but the camera, please.
بلى. Yeah.
Okay. Paywent Payro. He is present. The camera, please.
Yes.
Okay, nice. Payam Nabez.
بلا دكتور.
That's wash. Okay, Rabin Hussam.
Yes, doctor.
Okay. Rojan, she is present, but your camera, please.
بلا دكتور. ترجمتها دكتور.
إيه ليش صار بدأ خوش. سيوان رؤوف.
بلا دكتور.
داس خوش. سنجر سعيد.
بلا دكتور.
سنجر داس خوش. ساسان سردار.
كيان دكتور كيان.
كيان خوش بيه. شانيا دارا.
بلا دكتور.
داس خوش. شانيا معطي.
بلا دكتور.
اوكي. شازة عمر.
بلى دكتور كان.
اوكي. شانيا عمر, she is present. Where is your camera?
بلى دكتور. I'm
Okay,
here.
very nice. Sivan Sadiq.
Yes, I am here.
Very nice, Sivan. Soz Nasraddin, she is here, but where is your camera?
Yes, doctor, I'm here.
Okay, Varikawa.
بلى دكتور جان.
Varikawa. And Zelia.
بلى دكتور.
Okay, طاقات أزربتان موجودين. Okay guys, I'm so happy to be with you here. I hope it was
تجارب النايم للأخرى.
now chia.
ناوي مني الشيتيان أبو.
now it عفو.
دابان قادر.
دابان قادر. اوكي او بريزنت چی ترش هبو ناوی نخوێن درابوو
من فينا مهدي.
فينا هەر ناوت نەبوو لە لیستەکە
بابان قادر بابان.
اوكي سەرچاکێکم بەسەر چاو فينا مهدي.
بەڵێ
لەگەڵ
هەر هەفتەی پێشوو ژوا بوو هەفتەی پێشوو پێم وتی
باش ئەوە بابا ئێستا هەفتەی پێشوو بابا فينا مهدي باشە نووسین پرزن دوای سێریەکەن لە هینەکەش بابان قادر هەفتەی پێشوو هاتوو بووی
دكتور جان.
هەفتەی پێشوو هاتوو بووی
والله يدير ابو دكتور بس لازم لا اقول انا عقلنا انا وبس خدمته.
باش مهم
عايز اجيك لخدمتها
مهم الثقة هي أخوي. Okay guys, so as I said, I'm happy to be with you today. I hope the lecture was reproductive and informative for you. So if you have no any question, so we can go now.
دكتور جان عفو والله.
Go on, hello.
دكتور جان والله من هەفتەی پێشوو لێرە نەبووم جامەیەکە محازرەمە هاتوومەتە دەستەکەەوە جامێ بزانم هەموو دەرسێک بەم شێوەیە یعنی بەم شوەیە پرسیارەکەیت و بۆ هەموو سلایدەکان پرسیارمان لێکەی
والله